Barry.
Dr. Sumia, thank you so much for that generous introduction and for all that you do for us in the field of TB, distinguished chairs and colleagues. It's a particular thrill for me to be here. I only realized during the trip that it was exactly 50 years ago that I first came to India, invited by WHO for the first meeting they had run on leprosy and the possibility of developing drugs and vaccines for leprosy. And 2 years later, Dr. Talwar at the All Indian invited me to come and teach the first course in immunology. And I would say those experiences were the most determinative in changing my scientific career to thinking about using science to work on problems that affect people in the poorest countries. A most rewarding and gratifying experience. Let me just start with the first part of my rather pretentious title. Why do we need a TB vaccine? And one of them I would call the strategy problem. And the strategy problem is the logic of the program since DOTS was first started. The Big DOTS program is a perfectly reasonable logic is that if patients have TB, they'll be sick. If they're sick, they will seek medical care. And if they seek medical care, we know that there are drugs that can cure them and hopefully reduce the burden of TB. The fact is, as you can see, while there have been great progress in reducing mortality, the impact on transmission has been remarkably glacial, to say the best. And if it is the general law of infectious diseases that the key to controlling infectious diseases is to interrupt transmission, we are not succeeding in high-burden countries. That's a rationale to do something different, and one of those strategies, particularly relevant here in India, is to find people earlier than they would ordinarily come in for treatment. The second is the implementation problem. Even with passive case finding, when people finally are identifying themselves as sick and seek care, this is a very important, groundbreaking paper of a very great group of people, including Dr. Sumia, that indicated that we're talking about more than half of the people who come for treatment in India are not able to complete treatment or stay disease-free after a year. That is representative not just of India, but of 13 countries studied by a group led by the Gates Foundation, including South Africa. Then there's the MDR problem. While TB incidence appears to be more or less globally flat, it's up in some places, down in others, it is clear the MDR problem is increasing, and the cascade of care, as you can see, is even worse than one could have anticipated. And this, too, is a general finding that case completements are in the 11 to 14% range in many of the high-burden countries. This is a problem that needs to be addressed, and we have to do something different to do it. And clearly, vaccines represent a unique approach because they don't care whether the pathogen is drug-resistant or not. They work by an entirely different immunological, not chemical mechanism. And so this is an adjunctive to treatment and is essentially critical. And finally, there's the quality of care TB problem, I would argue, and that is much in the majority of healthcare, for example, in India and Indonesia and some other countries, is private, not just public care. And that leads to many poor people having huge burdens of out-of-pocket costs, not reimbursed by any kind of insurance scheme. And so if one looks then at, as has been done, again with support from the ministries of health here and support from the Gates Foundation, what is the proportion of people that have an extended cough and classical symptoms of TB? What is the chance they're actually going to get to a provider? And as you can see, that 3/4 of them, even though they have symptoms of TB, either don't know it or don't believe it's important to get early diagnosis and treatment, so they don't show up at the public health facilities. If you ask the question, how many healthcare providers does a patient have to see before someone figures out they might have TB? The answer on a statistical basis of sampling here, I have to see 3 providers before one gets the diagnosis right. And if you then ask the question, if you provide the symptoms to a survey of physicians, about 25% are able to tell you what the WHO diagnosis would be, and only 25% of an independent group of physicians actually knew what the WHO standard treatment for TB was. These are enormous problems, and the conclusion that I draw is they justify the need for vaccines. And I would emphasize here, I won't talk about specific new vaccines. I'm thinking that in the short term, we have to think about more than one vaccine. The idea that there's going to be one vaccine that protects all the groups that are susceptible, from children to the elderly, is, I think, a wishful thinking, and so we need multiple vaccines that do perhaps some different things. One of the things I learned from leprosy that I think is applicable to tuberculosis very much is it is not a single disease entity, but it's a spectrum, and that spectrum correlates to some extent with innate immunity. And so there are a small number of relative people that have tuberculosis, but would be skin test negative, but they're asymptomatic and they're not sick. But if they're tested with GeneXpert, as was a recent paper in Vietnam in contacts, they have acid-fast bacilli, and some of them are even smear positive. But there is something called asymptomatic TB, and that's the earliest place we need to find people. Then, of course, there's the latent TB and chronic TB, which is another category not well thought about, of people who are, again, asymptomatic, acid-fast bacilli positive. Case in a school in St. Louis in the US, 435 people were infected by a single school teacher who thought he had a smoker's cough for 10 years. That's a dangerous population that we don't really recognize and don't address. And then there is, of course, the immune responses developed to wall off TB in the lung. Then the point is that there are multiple places of intervention. We've heard about those before, and they may require different strategies and different targeting. The prevention of infection, prevention of disease, and prevention of recurrence. And in places like South Africa, half the recurrence appears to be reactivation of the initial strain, and half the new recurrences are due to new strains and reinfection, which is problematic. And clearly, one of the goals of the vaccine business is to prevent disease and interrupt transmission and bend the curve of incidence. So what would we really like to know to develop a rational vaccine, which of course probably has never been done, and trial and error is the standard operating procedure. But if we had our way, if we had enough knowledge, we'd really want to know what the mechanisms that are necessary and sufficient for production are. Necessary, we know a lot. We know gamma furon is necessary. We know CD4 cells are necessary. But we don't know what combination of mechanisms will predict protection, and that's what you really need to evaluate new vaccines. We don't know what antigens, I'll say a little bit about that, are required for protection. We have really no idea. We need to have a delivery platform or platforms that generate those specific responses in the first point that will guarantee protection, and perhaps we could use non-human primates and other animal models to tell us that in an easier way than it is to do it in humans. If we had such mechanisms, we could then confirm those in studies generated in translational research in humans, because as you will hear, there are many differences between animal models' immune responses and humans in this field. And the ideal would be to develop a set of biomarkers where you would be able to predict whether someone who's been immunized is in fact likely to be protected. So the question is, In a world where two major vaccine trials are seen as not having succeeded, the South India trial, which I'll talk about, and the recent antigen 85A trials, there's a huge skepticism in my field that it is even possible to produce a TB vaccine. So let me make the case that it may well be quite possible if we knew what we were doing. And the first is an old paper that I treasure from Johannes Heimbeck in Ullevål, Norway, who studied nurses who came into the hospital and were exposed to TB patients. And what he found is, in this case, there was a needle test, not intradermal test, called a Puricate test. And what he found basically is that if you looked at the nurses who came in that were tuberculin negative, they had a high rate of tuberculosis, infection, and a quarter of them in the 3 years of their training got active disease. And 0.6% progressed from infection to disease. But the relevant point is those who came in that were skin test positive had a 96% less rate of incidence of disease. That is, latent TB was protective in those studies. And that's an important thing to try to figure out. If you then study the 14 studies and trials that were retrospectively analyzed by Jason Andrews and colleagues when they were in Boston, what you find is that latent TB in retrospect was about 79% on average protection against TB. And this surely has to indicate, since we know latent TB is a risk factor for getting tuberculosis, we have to understand why latent TB is so effective in these studies in protecting against TB in Norway and some other countries. The challenge then is to develop a vaccine as effective as latent TB. Is BCG that vaccine? And the answer is it is not. Because in 1948, the same Heimbeck, looking at the same nursing students, found that after BCG came out, he repeated the experiment, and in essence, BCG was only half as effective as latent TB in preventing observed disease, and certainly it was better in preventing mortality, which still occurred and was basically done before antibiotics existed. So I would infer from these studies that it is for sure possible to prevent a disease, but not 100%. And BCG is good, but not as good as what we have seen here. When one analyzes, as many studies have done, BCG protection against disease, one finds that it's about, on average, 50% protective, which is really not as bad as most people think when we say BCG is a terrible vaccine. 50%, given the challenges, is probably not that bad. There are some retrospective studies, and you will hear studies tomorrow that are more recent, looking at the question, can one prevent infection, which would be the first step in prevention in dealing with TB. And again, retrospective studies not designed to test this question suggests that, in fact, BCG had about 25% or 27% protection against infection when compared with the 50% approximately, or 57% protection against disease. So we know it is possible to protect against tuberculosis. We need to do better, and we don't know why we're not doing better. One of the reasons is this peculiar business that you all know of the variation in TB protection in different parts of the world. I show this, these are observational studies, but they illustrate the range of variation. The relevant points are that in the UK, BCG in very major trials was highly protective, about 77% protection in both randomized control, as you'll see, and observational studies. And in the South India trial here, it was 0% protection at any age group. So if one looks at the South India trial, this was a magnificent trial, one of the largest ever done, brilliantly designed and executed. 260,000 people followed for 15 years, and the result was no protection versus disease. at any endpoint. Regrettably, they weren't able to do TB meningitis in children. Had they done that, they would have been the first probably to show that BCG does work very well against meningitis and disseminated TB in kids. So what are the reasons that we can think about? And they've been speculated for many years, and I won't go through them. There are many, many reasons that have been proposed. There are no data in the trial to allow us to analyze why greater protection wasn't seen, but the most likely candidate for the explanation, in my view, is the interference by exposure to atypical environmental mycobacteria. In England, adolescents that were in the trial, 4% approximately, were tuberculin positive to an avian environmental PPD. And when that same PPD, called PPD Batty, was used in the South India population, not in the trial, but the population, 9-year-olds were 80% positive to an atypical skin test, and 12-year-olds were over 90% positive. So the exposure to environment in India is very, very high, and I think recent studies, contemporaneous now, using quantiferon tests, are finding the same things. And of course, there may be other reasons that we don't understand. I infer from that some conclusions. One is the hypothesis of the South India trial, not a criticism, because it seemed like an obvious hypothesis, is BCG worked in England, BCG worked elsewhere, it had to work in India. And that was the only hypothesis in the trial. So every trial has to have multiple endpoints. So if it doesn't produce the desired primary endpoint, at least we can learn from it. And second, I think one has to take very seriously, in India, particularly in trials, of the exposure to environmental mycobacteria can inhibit the ability of any vaccine to show greater protection than the environment induced itself. The question is, how specific does the vaccine have to be? How TB specific does it have to be? And I would point out, most people are not aware of that in the great MRC trial, following 54,000 tuberculin negative adolescents in the UK, there were 2 vaccines used. One was BCG, of course, a bovine, and the other was Mycroti, a mouse TB that people never see. And it was not given intradermally, and I've never understood and found no one who can tell me why BCG is given intradermally. I know why it's no longer given orally. There were bad adverse effects seen in some children. But this was developed by a device with 40 needles, 2 millimeters in length, that were stuck in the skin, and we would call that, the newest fad in immunology is transdermal immunization. It gets into dendritic cells and probably went systemic. The protective efficacy in the British MRC trial with Mycroti and BCG were identical at 84%, and 20 years later in that same population, it was 77% protection. That really does say that in that population under those conditions, BCG was protective. I would point out that since 1931, a slew of major antigens in M. tuberculosis are not in BCGs. And one may think about, as we think about booster shots and secondary vaccines, some of these are virulence determinants, but as antigens, they might be useful to include in new vaccines, and not all have been. Clearly, vaccines, to have a greater chance of success, have to contain multiple antigens, and the question is, which ones? I'm always puzzled by this choice of the intradermal BCG, and I happen to know some of the people who did these old studies in rhesus macaques, and they're currently being done contemporary by Bob Cedar and Joanne Flynn, and the results are very striking. That IV BCG in a highly susceptible monkeys, rhesus macaques, produces minimal, protects against major lung damage. And if you look in the lower right-hand column, it's virtually 100% protective in terms of involvement of the lungs, lymph nodes, and hematogenous spread. How does one have been surprised about is that there is so much attention to CD4 cells and a whole variety of T cell subsets there's been relatively little attention to CD8 cells. And when Joanne Flynn was a postdoc in my lab, we knocked out MHC class 1, which is required for this. And as a consequence, if you look at the lower curve, that's animals that had no immunization, were challenged with TB. The upper curve is the growth of the TB after challenge. If you look at the animals immunized with BCG, what you find is that if you knock out the class 1 killer cell phenotype, the M. tuberculosis grows even after immunization with BCG. But if you look at the right-hand column, without any immunization, you don't need killer cells to produce protection against BCG. So I think one of the things we see there is BCG in mice doesn't induce very well and doesn't require CTL for protection. That's probably a difference to be pursued in tuberculosis. This is a study of a group looking at monkeys that were immunized and challenged in the lung. And again, it's anti-CD8 antibodies. If you knock out the CD8 cells, as you can see in the left on the upper curve, they're the same as not having immunized the animals at all, the naives. And if you look in the lung that was challenged, you can see that there was a very high degree of protection in the lobe of the lung that was challenged that went up when the CD8 cells were knocked down. So I think this is an area that requires a bit more attention. So why do we need more human studies? One of my messages is we need more human studies. And this is just a small list from just our own studies with Robert Maudlin and Stefan Stenger, looking at killing by human macrophages and how it differs from studies in other animals, and particularly mice. And I won't go into any detail. There are multiple mechanisms that macrophages from humans use to kill TB in vitro that simply do not exist or do not have homologs in mice, and even in monkeys may or may not exist, and they should be explored. And that's why I see no alternative than finding ways to get more information on how the immune response in humans, whether it's in latent individuals or vaccinated individuals, work. There's an aspect that has puzzled people and I think is now a new area of interest. We know that there are good data that show that BCG actually protects against a heterologous organism, Mycobacterium leprae, and it protects pretty well. But there are all kinds of reports to show that children who are vaccinated with BCG have a reduction in 5 very low-income countries in Africa of all-cause deaths in children under 5, acute respiratory diseases in infants. It is the standard treatment for bladder cancer in most countries, and there's some tantalizing, unconfirmed yet, or verified reports that it may have an impact in treatment of diabetes and in multiple sclerosis. How can that possibly be? And I think there are recent answers that have come in the last 2 months of 2 papers, one from Canada and one from Europe, showing that if you allow BCG to get into the bone marrow and in mice, you totally alter the stem cell, hematopoietic stem cell population. There are epigenetic changes in both cases. In the figures on the left, there is a nonspecific transferable protection against tuberculosis, and the right is BCG experiment in human, where there is a heterologous protection against live yellow fever vaccine as the challenge that is unexplained by specific immunity and has much to do with some sort of innate immunity and epigenetic changes. And epigenetic changes are interesting because they're long-lasting. So even if you have a short-term immunization, if there are epigenetic changes, that cell lineage will carry those for the life of the individual and possibly beyond. So I would make a pitch that we would do very well to try to understand what are the possible immunologic differences between M. tuberculosis latent infection or TB infection in animal models and other vaccines. Because we think from the old studies TB is doing better things than TB, and there are a list of mechanisms. The major one is there are a slew of antigens, as I showed earlier, that are some of which are involved in pathogenesis that do not exist in BCG. BCG doesn't need or generate very effective cytotoxic T cells. There are killing mechanisms that appear to be generated by TB infection that may or may not be well done by BCG. And one of those is the molecule granulysin and granzymes that actually are able to kill TB in infected cells. If you just lyse an infected cell with killer cells, you disseminate the infection. But if you have these molecules in T cells able to kill the target cell, they can also kill the intracellular bacterium. There are recent studies indicating that certain isotypes, particularly in tuberculin-negative, highly exposed individuals, may activate macrophages to kill TB, and the idea that BCG or TB may persist in the bone marrow in a stem cell population may generate innate responses that could be very valuable, and we would have to mimic with any vaccine. And of course, there's lots we don't understand about those immunologic differences that we need to study. One other thing, if we're talking about what we can learn from BCG, it turns out even if it's not the greatest vaccine ever invented, it is remarkably cost effective that Chris Dye looked at and Catherine Floyd in just protecting children against disseminated TB, meningitis, and severe problems in kids. And the economics of that, as you've heard from Richard White, is very, very favorable. It's highly cost effective. But what I would warn is, on round figures, it costs about $1 million to produce one vaccine, at least in our country, acceptable for the Food and Drug Administration to be able to be tested in humans. It costs about $5 million for a small study of the immune responses to vaccines in humans, or perhaps short-term protection of infection or reactivation trials. And for a real efficacy trial, we're talking about very large sums of money, $1 million, $100 million. So that one of the things I would point out is vaccine trials either work or fail. Vaccine research, if we learn anything, cannot fail. So I would be cautious of how we present learning experiments in small numbers of human volunteers. These are research, translational research projects where we're trying to learn things. And if we learn things, they cannot be counted as failures. We have to be very cautious about what we promise people and how we describe what we do. So I will conclude by thanking people for the privilege of sharing my own opinions of what needs to get done. And I would put very high priority on translational studies in humans, small studies to learn immunology, measure everything that we can measure, to try to define what are the immune responses that seem to correlate with protection in latent patients, in people who receive vaccines, measure as many things as we can, biobank cells, and put things away that they can be studied as new knowledge develops. And I think one of the things that one has to think seriously about, since trials are so enormously long against disease, you'll hear possibilities of creating M. tuberculosis strains, like in malaria and typhoid fever and other vaccine studies, are challenge experiments, safe challenge experiments that could be controlled, where we could get very quick answers as to whether the immune responses generated by a vaccine are able to kill input M. tuberculosis. Clearly, we need more field sites. There aren't that many sites in the world to test vaccines. There are more vaccines than we have field sites, but they have to be connected at some level with good laboratories that can teach us what's happening and identify correlates of protection. We need a larger pipeline, I think, of more creative and imaginative vaccines. We need greater finances. And finally, in my view, and I think what I would like people to believe, is that the only vaccine studies that fail are those from which we fail to learn. So maximizing learning and sharing that learning with not just the scientific community, but the entire civil community, the press, indicating that we're making progress and not delivering expectations that can't be delivered. That's a challenge for all of us. And with that, I thank you all very much for your attention. Where we are now is we have a big problem and very small tools. Thank you.
We have time for questions for Barry.
Could you use the mic, please, and introduce yourself before you ask your question?
Sure.
Could be question or comments, but please keep it short.
Sure.
Thank you.
Deepak Kaushal. Hi, Barry. Great talk. If TB protects both man and monkey better than BCG, then shouldn't we start with TB and de-risk it as our next vaccine?
So as you know, 25 years ago, my lab started by creating auxotrophic vaccines, knocking out essential genes for vitamins and amino acids, and they protect mice very, very well. Whether they would protect humans is unclear, but they've never been seriously tested. With CRISPR-Cas9 and modern technology, as I think you will hear from Eric Rubin, it's possible to design M. tuberculosis vaccines, the growth of which can be controlled by external additions to diet or switches, so that it would seem to me that's a real possibility that would have all the antigens of TB. That's what we had originally tried to do, and yet are not able to grow. The question is, how long does the immunization have to persist to have a long-lasting effect? And that's why with any of these TB vaccines or subunit vaccines that are not going to last very long, we have to think about prime and boost strategies that we might not have to when you have latent TB that persists for very long periods of time. I think it's possible.
Thank you very much. My name is James Kamau from Kenya Treatment Access Movement and in the civil society. I'd like to ask you, one of the things you said is 25% of doctors and providers, to put it in activist language, know zero or don't know anything. How can you, what do you propose can be done to start getting them on board? Because even this vaccine that we're pushing for, the other ones that will be able to deliver, and it's important that they know it. And then secondly, how can this kind of vaccine implementation, how can you involve the doctors or the medical universities all over, so that as the doctors are coming out, they have an idea of what it is? Because frankly, me as a person living with HIV, positively living with HIV, I find I am more medically knowledgeable to very many doctors. Thank you.
Wonderful questions. A huge challenge. So if 3/4 of the patients with TB see 3 providers before they get treated and before they get diagnosed, and treatment is not maintained, we don't know if those providers even notify the government. It's a legally notifiable disease. It's very hard to know how good the programs are and whatever. So there's a special challenge in countries where a lot of medical care is given by private physicians. And as you know, in India, healthcare is largely a statal issue, whereas health research is a national issue. There are tremendously exciting efforts underway, led by, and Sumia might know much more than I do, in 5 cities in which private care physicians have been brought together with the public sector. There's some NGOs that are able in slums in 7 cities that I know of, where they identify patients with cough, with local active surveillance, if you will, symptomatic surveillance, and then the drugs are provided by the government and oversight for treatment. The DOT itself is observed within the slums. So the efforts have to be made to reach out to the private clinicians. So that's not easy to do. They have to be involved and feel they have a role to play. And there are electronic ways to link them to the notification systems to make them a better, even better at what they do in other diseases. The challenge to private physicians is if you take their patients away from them and send them somewhere else, they won't get their patients back. And that's an assurance that is being worked out in these 5 studies. And it's my understanding those studies will now be extended to 31 cities here as part of the Zero TB movement. The second question is a really interesting one, and is how do you engage private physicians in a research enterprise? So I've been privileged over the last few years to chair the Research Advisory Committee to the Public Health Foundation of India. And it is one of the world's resources in non-communicable diseases, heart disease and diabetes. And doctors Srinath Reddy and Prabhakar have giant clinical trials of antihypertensive drugs and anti-cardiovascular drugs and diabetes drugs involving over 1,000 physicians, where they get monthly phone calls and are considered essential to and part of the research operation for which they get no pay. But being part of a research operation for a priority within the government of India, when it is organized well and people are not just sending patients, but receiving knowledge and advice back, is another way to engage that sector in a research enterprise to be part of something that we think is going to be very important. And lastly, I would say from the civil society sector, one of the problems in vaccines of many kinds in the past is a laboratory somewhere invents a vaccine, they show it works in mice and monkeys, and then flies into a country and says, now it's time to vaccinate all your kids or your teenagers with our vaccine. It is difficult to get that to work, and it's not right to get that work. And at the early stages of involvement of clinical studies, I think it would be very important for the civil society community to get in and be aware of what the vaccine could do, what the adverse effects we would expect to do, and conversely, we can anticipate what the reaction would be. And as you know, with the original introduction of HPV in India, it's a fantastic vaccine. It protects spectacularly well of cancer of the cervix for women and head and neck cancer, which is the most rapidly rising cancer in men over 50. And yet, because it was rolled out without great community involvement, it was a public relations disaster. And millions of young women are going to be doomed for cancer because of that. So all the private sector, public sector, and communities, in my view, have to work together. Carlos?
So I think Carlos, and then Pallav, and then the gentleman over there at the back, and then one in the middle. Yeah, we'll probably have time for those 4.
Thank you very much. It was very stimulating talk. I think we learned many things. I would like to do a general question. One is when you present that the infected people is protected so high, and then with the Dr. White, Richard White, say the theory that it will be good to do the studies on the adolescents, because I think the impact will be better for. I'm talking about the clinical trials for efficacy of a new vaccine. And then with the data Dr. Suleiman Sawita said about the number of the people who is infected, that will be 80%. So which is your guess to test a new vaccine? Do you think the adolescents, that they are so high incidence of quantiferon positives and so high that negatives that we don't know they were infected or no, it will be good, the theory, to test the efficacy of new vaccine then, or better like MBA?
I think it's a huge challenge, and I think that what one has to think about is in any trial, in a country that has a high spontaneous rate of tuberculin positivity, suggesting that these people are already exposed to and possibly latently infected, why would you expect a different result in the South India trial 50 years ago? So I am very strongly of the view that one has to design the trial in such a way that at least a subcomponent is naive and not exposed in the trial. So if BCG given under modern conditions and compliance and all of that with the immunologic tests we can do works, that would be wonderful, but it would be unprecedented. But if it doesn't work in people already infected, adding more BCG to whatever they already have with their latent infection, then we either need antigens that are not in BCG but in M. tuberculosis as some sort of booster, or more importantly, we need a subset of recipients that is negative by quantiferon or skin test. Otherwise, one risks the possibility of seeing no effect of a vaccine that in a different population might have a very big effect.
Pallav Bagla, correspondent for the Science magazine and science editor for New Delhi Television. A slightly political hot potato for this audience. If you're going to end TB by 2025, in 100 years you haven't gotten a vaccine, a new one. You're not likely to get a new one in 7 years. Why are you wasting money? Soumya, you can take, and Barry, you can contribute.
If you do, there's an adage that Albert Einstein defined madness as doing the same thing over and over and expecting a different outcome. So the answer to the question is, if we don't do anything, we know what's going to happen. It will take 150 years with the present tools to bring tuberculosis down to some reasonable level. I don't promise anyone to end TB. I think those are very difficult projections for any scientist to make. I think we need new tools. And for example, if we had earlier diagnosis before people are sick, before they've spent enormous amounts of time transmitting their infection within the households, before a member is detected, we have a real shot with the present tools of moving things forward. But given the inefficiencies of the healthcare systems in many low and middle income countries, it seems to me a very small investment to say we could provide a tool that, as you saw from Dr. White, if it was even 20% effective, it would be cost effective. If a new vaccine were 60% effective, the government would actually save money. It would be cost beneficial in the models that exist. And relative to the cost in billions of TB, we're talking about a few $1 million of increment to support research and clinical trials. That would seem to me a really good buy. And I would hate to have people say, because we don't have a vaccine tomorrow, we shouldn't have a vaccine ever, particularly with the rise of drug-resistant TB.
And Pallav, I don't have very much to add to what Barry said, but I think what the targets do is to galvanize the community, both the science community as well as the political establishment, to focus on a problem. And I remember many years ago there was a US president, I don't know if it was Clinton, who said that we should be able to solve the problem of cancer in 10 years. Nixon. Yes. And of course we didn't, but what it did was, where are we today in cancer? We're far, far ahead of where we were, a few years ago. We've got personalized treatments. We understand so much more. So I think that's the hope with which we need to move ahead, and to pursue the leads, and also to design studies, as Barry pointed out, where every study we do, we learn something more. It's not a question of whether the vaccine failed or succeeded, but we understand something more about protection. And TB is a complex disease, and it may take more than 7 years to get the vaccine, but we have to keep working at it. Meanwhile, we have tools that we can use. And Luchika is dying to make a comment. Is it It's on this point, so please.
It is on this point, because I was sure we will be asked. So thank you very much, sir. I want to say two things. One is, it's India who aims to end TB by 2025. It's not the world, okay? And we are all thrilled by that. So for the world, we are looking at countries that are actually putting that target even beyond what SDGs are saying, but to 2035. I heard even a country saying maybe 2037. I don't know how that cutoff point came. And for every single one, a vaccine will be essential. And what will be essential here, in addition to what was said, is the fact that we need to make a difference between eradicating TB, eliminating TB, and ending TB. And for the purpose of the conversation of the SDGs and all the metrics, ending TB doesn't mean zero. Ending TB means a cutoff point of 10 per 100,000 at global level. So it means that it leaves us a huge number of cases still there. So even if we will be able in India, and I hope we will, to end TB by 2025, we will still have a huge reservoir globally that we will have to tackle with a vaccine that hopefully will come before 2025. So this is, if you want, we can continue later. Thank you, Madam Chair.
The back, please, and then the last question from the middle there, yes.
Hi, Barry, this side, this corner.
Oh, hi.
So I was just wondering, you elaborated a little bit on the vaccine antigens. Can you comment a little bit more on what is the problem with the vaccine antigens?
We don't know which ones are required for protection.
And
We know which ones people's T cells see, and the predominant antigen the T cell sees was the antigen 85, and it didn't show protection. And one of my colleagues in London said, why would you expect an antigen that everybody with TB sees to be a protective antigen? Why not look for antigens that people don't see? And we haven't done that. But the answer to your question is we don't know what antigens are necessary to generate a protective response.
Okay, let's take the question from the middle here. Yes, sir, please.
Okay, my name is Sudhir Sinha. I'm from SGPG Institute of Medical Sciences, Lucknow. Hello?
Yes.
I think you have already partly answered the question, because we are in India, we are talking about giving a vaccine which is superimposed over latent TB infection. And I think close to 100% people are having LTBI in India, as it was told in the morning. So LTBI has already done or modulated your immune response for better or the worse. It has and the infected person has already seen all antigens which are there in MTB. So under these conditions, if you superimpose a BCG vaccine or any recombinant vaccine, how is it going to help?
Questions to save time, and then you can respond. So Dr. V. Chauhan in the front, and the gentleman over there, are you waiting to ask a question as well? Oh, you have a mic here, please. Yeah, thank you. So this will be the last one.
How realistic is the goal for having a human challenge model as you have in malaria, particularly if you have one to bring it to a country like India? First of all, is it an achievable goal given the nature of the bug?
The answer is yes, and Eric Rubin will give a presentation on that at this meeting, I think tomorrow. It's not there yet. Conceptually, it's brilliant. Whether in the real world it proves to be fulfill its expectations is unclear. What the challenge is to make it from M. tuberculosis and to make it guaranteed safe. And that's the challenge for any challenge strain. And I think they are working on it in a brilliant way. And because of the non-human primate models, it's quite possible to test it as to its safety and efficacy in non-human primates before one gets into humans. So I think It's very possible, and I think probably close to necessary. The questions that both Carlos and you asked about how to think about immunizing people who are already being immunized by latent infection or environmental mycobacteria in the Indian context. I believe that by the time index cases are found here, they have already mostly transmitted to most members of their households. And if I were to say one wish globally for a change in policy, as we want to get people earlier and earlier in their infection, we're going to have to go back to what worked in the United States and Europe. We're going to have active case finding. TB was dropped in the United States after World War II with no antibiotics. It was dropped by every school kid like me, was skin tested every 3 years. The annual risk of infection showing whether the community is diminishing in the number of children infected by household contacts was measured as a measure of the effectiveness of the public health system. I had x-rays several times in school and before I went to college. Everybody who worked in a factory had an x-ray. X-rays are not the most specific tool in the world, but that's what did it. People that had TB were either isolated, sent to sanatoria, or kept at home, and TB dropped precipitously. Economics after the World War increased, ventilation and housing increased. One can't attribute solely to active case finding. But if you want to be able to test a vaccine before people are infected, you have to find household contacts early after people are infected, and that means trying to get into index case households as early as possible and possibly high-risk communities. There is a tool that is now very exciting, been done in Kenya, where you don't need expert readers. These are fully computer automated X-ray readings, and they are adjustable in how specific you want the diagnosis to be made. And when linked to GeneXpert or a molecular diagnostic, you set the window at 70% so that you get a good screening for those who do not have likely TB and only spend your money on the 30% in the molecular test to confirm or disconfirm the diagnosis. I would think that would be a tool that could be very useful in catching people with early disease earlier than just household contacts. But that requires a whole big commitment of the system. But I think the answer to the question is it's going to be very difficult to take people already infected with TB that haven't been able to get rid of their organism but are holding it in check. And whether you can vaccinate those people to prevent recurrence or progression is the reason you do trials. We have to know that.